Yes, sir.
I'm recording the session. Good evening, everyone. Welcome to episode number 3 of season 4 of ICPA Clinical Series. And for those who are not aware, ICPA Clinical Series is built on the theme that each episode solves one clinical challenge. Each episode, one clinical challenge, and every time we try to keep it as clinically relevant as possible. And today we are privileged to have two endodontists with us. Our guest speaker, Dr. Amlani, micro-endodontist from Vadodara, and we also have our guest moderator, another endodontist, Dr. Urshita Jikar, again from Vadodara. Urshita will join us in the discussion for question and answer session once Dr. Harsh's lecture is over. And before he starts his lecture, I take this opportunity to introduce Dr. Amlani, who did his BDS from Bharati Vidyapeeth Dental College, Pune in 2006. And then he worked as a dental surgeon in Vadodara for 2 years. And then he joined M.A. Rangunwala Dental College, Pune for his MDS in endodontics. And Dr. Harsh has been actively involved in various clinical research activities since his post-graduation and has various publications in national and international journals. And since 2012, Dr. Harsh has been practicing exclusively as a micro-endodontist and a consultant endodontist in Vadodara. Dr. Harsh was conferred with Special Jury Excellence in Dentistry Award, Endodontist of the Year in 2014, and he has been conducting courses and training programs for beginners, teaching them modern endodontic therapy across India. And he is also a faculty at the International Endodontic Program. His main interest remains in advanced microscopic endodontic treatments and retreatments, including surgeries. So without taking more time, I invite Dr. Harsh to start with his presentation. Dr. Harsh, you can share your presentation.
Good evening, everyone. Thank you, sir, for the wonderful introduction.
Click on share and entire screen.
Yes, sir.
No. Cancel.
Yes, sir. Good evening, everyone. First of all, I would like to thank Dr. Rajeev, Chitguppi, sir, and ICPA team for inviting me on this platform. Hi, everyone. I'm Dr. Amlani, and I'm a practicing micro-endodontist from Vadodara. And today, I've been asked to talk about one of the most important topics in endodontics, which I consider is a cornerstone for the successful endodontic treatment, is obturation. If we look at the definition of endodontics, according to American Dental Association, it is nothing but a branch which deals with the diseases and the treatment of the pulpal tissue. But what I would like to highlight for you here is that we as an endodontist are not only concerned only with the pulp, but the associated periradicular tissues as well. To make you understand this, we as an endodontist have to have a holistic approach towards the periradicular tissues. As for example, if you look at this case where the previous operator attempted to heal this lesion, she was not successful in locating the canals of the other teeth. But with the proper endodontic treatment and follow-ups, you can see 1 year down the line, the lesion has healed. So what I mean by taking care of the periradicular tissues is that we have to maintain the decorum of endodontic rules. We do not have to violate the endodontic guidelines by pushing our irrigants and endodontic materials in the periradicular tissue. When we talk about obturation, what do you understand by obturate? Obturate is to fill the shape of the debrided canal with the temporary or the permanent filling material. It is just the way we cork the bottle so that the ingredients do not leak from the bottle. The same way we cork the canals so that there's no chances of micro leakage in the canal. It is a known factor that a chemomechanical preparation, canal disinfection, and obturation lays the cornerstones for the successful endodontic treatment. Despite knowing this, why do root canals fail? I have been quite frequently asked, why do root canals fail? Now, if I go on listing a number of reasons why do root canals fail, it will take another 2 hours. But one of the major factors in the failure is attributed to inadequate obturation. Ingle reported 58% of the root canals failure are attributed to inadequate obturation. That means the canal spaces which are not obliterated by the obturating material leave behind spaces for microorganisms to recolonize and cause failure of the well-treated tooth as well. If we look at the historical perspective of obturation, what obturating material we are using today is because of the constant efforts by our predecessors where we have evolved with the latest material. For example, if you look at this X-ray, this goes back to 200 BC, that is 2200 years ago in the Nabatean warrior. If you look at the X-ray, you see there is something is filled in the canal. It means the obturation is not an old technique. There used to be something were used to fill these canals. But over a period of time, we have evolved and we have come up with the newer and the latest techniques and the materials. Before 1800s, the root canal fillings were done in gold. Later on, they were evolved and they were filled with a hill stopping. It is nothing but a preparation of a bleaching gutta percha and carbonate of lime and quartz. It was in 1867 where Bowman was the first one who is considered the first person to use gutta percha in the root canal as an obturating material. Since then, the gutta percha has been the mainstream and the main obturating material. Still, it has stood the test of time. With time and again, I have been asked this question quite often. What is the purpose of obturating the canals? Why can't we just clean the canals and give a coronal restoration and leave the canals as it is? Answer lies in your own home. It is just as when you leave these water tubings open in your attics and your terraces and where the water gets filled up in these tire tubings. These will attract colonization of algae, bacteria, and mosquitoes. The same goes with the canals. When we clean and shape them, we leave the canals sterile. But when we leave these canals and there's a break in the aseptic chain, bacteria colonize these canals and there's a reinfection of the periradicular tissues. Even Schilder described that the main objectives of obturating these canals is to obliterate the canal spaces which were previously being filled by the pulpal tissue, to prevent the recurrence of the infection by way of sealing the coronal as well as the apical exits, and to develop a fluid-tight seal. Many of us use a term hermetic seal. Hermetic is a misnomer because hermetic seal refers to the condition where we need air and fluid to seal the compartment. Here we are dealing with only oral fluids. So a fluid-tight seal is an appropriate term. I would like to address that. A second $1 million question is, when do we obturate the canal? When I ask you to obturate a canal, when you open up a tooth and a pus is oozing from the canal, would you like to obturate such canal? No. Under no condition would you place your gutta percha or any intracanal medicament here. So under no condition a tooth should be obturated if the patient is symptomatic or there is abscess draining from the canal, or you do not get a dry canal, or if there is an exudate coming from the canal. Second condition is if the patient is symptomatic or if there is an extraoral swelling in the periapical region. Under no conditions these canals should be obturated. In the olden days, there was a trend to obtain a bacterial culture from the canals by putting up these paper points, and these paper points were used to send in the labs for the bacterial culture. But these techniques took a lot of appointments, and if the patient do not turn up on time, there was a break in the aseptic chain. So this concept is no more practiced now. Once you see when the canal is dry, patient is asymptomatic, there's no swelling, you're good to go. You do not have to wait for the periapical lesion to heal. It will heal on its own once you have removed the causative factor. All have fears. I am scared of heights. What are you scared of? But when it comes to endodontics, I am scared of this overfill, especially with thermoplastic obturation techniques. If by any chance, if we tend to push these materials beyond, we all know that it will adversely affect the prognosis of the endodontic treatment. Till 1950s, there was no consentment till what level the root canals should be filled. It was just arbitrarily filled till the level they get the resistance. It was only after 1955 where Cutler carried out an extensive study on 300 extracted teeth and came out with the astonishing results. What Cutler described was that the apical foramen, we call as the apical foramen, the shape of these apical foramen range from oval to oblong to ribbon shaped. And not only that, these apical foramen had multiple exits, not one, not two, but multiple. And what we are treating is the only mainstream canal. What about these extra apical foramen, which we were never aware of? It's all dedicated to Cutler's study. But now we are aware that there are multiple portals of exits available from these apical foramens, and it's difficult to clean and fill. Not only that, he also described something called as a minor or the major apical diameter, what I term as the apical control zone. It is very important to know where our endodontic instrumentation and endodontic obturating material as well as irrigants should end. Anything which goes beyond the minor apical diameter is we are violating the endodontic guidelines. We are entering the periodontium. So our intracanal procedures should terminate at the minus at the constricted foramen. Anything which pushes beyond is we are over instrumenting and we are pushing our intracanal medicaments and irrigants beyond. Cutler reported that the average distance of these foramen range between 0.5 to 2.5 millimeters, and this distance increases as the age advances due to the deposition of calcific metamorphosis in aged patients. Due to dystrophic calcification, you will see that this distance increases between the minor and the major apical diameter. Now, how is it correlate to the clinical scenario? When we are obturating throughout our dental schoolings, we have been taught to obturate till the radiographic apex. And when you don't reach the radiographic apex, we tend to push these instruments and obturating materials so as to reach the radiographic apex. Now, what happens in real scenario? Let us understand through this picture. As I said, there is a minor apical diameter and there's a major apical diameter. What you see here is the anatomic apex, which is a minor apical diameter. And what we tend to obturate is still the radiographic apex, that is the way beyond the minor apical diameter. So what happens when you take an X-ray, when you superimpose these gadapacha cones, they superimpose and they match with the radiographic apex. So from one angle, as I say, IOPA is a 2D, two-dimensional image of a 3D object. So when we superimpose this, due to superimposition, it seems that the gadapacha has reached the radiographic apex. But when you remove this tooth and extract this tooth and see, actually this is beyond. So if you ask me how to determine this minor apical or the anatomic apex, you rely on a very standard apex locators. If you ask me whether to rely on apex locators or radiograph, I would say apex locators, because especially if you're using a standard ones, not the Chinese ones. To illustrate this, just have a look at this X-ray, which I have kept here. My obturation is still this black line. That is a minor apical diameter. What has gone beyond is the sealer, what we call as the apical puffs. Are these puffs good or bad? I'll come to it later on. Cutler's study also reported that more often than none, rarely the apical foramen coincide with the radiographic effects. In most of the cases, there are deviations. Now, these deviations occur in 92 to 95% of the roots, and the average distance between these deviations is between 0.5 to 1 millimeter. Now, what happens in this? Why is it important to know these deviations? Because when we do not know where our apical foramen is ending, we tend to push our instruments and obturating material, and we tend to transport and cause strip perforations or transportation of the apical foramen in the apical 1/3. Whereas if the debris is present in the lateral foramens, that is enough to fail an endodontic procedure. Now, one of the disadvantages of two-dimensional radiograph is the story tells a different radiographic story is something different. Whatever we see on the radiograph, everything looks black and white. Why is it so? Is it advantageous or disadvantageous? I would say disadvantageous because we do not know what the canals are filled with. Whether canals are filled with silver points or any restorative materials, any cements, gutta percha, only sealers, or intracanal medicaments, we do not know. Everything looks black and white on a radiograph. Over a period of time, a lot of materials have been tried and tested as a root canal obturating material, ranging from zinc oxide to zinc phosphate, polycarboxylate cement, lime, quartz, gold wires, and whatnot. We are always in the quest to obtain a material which meets the ideal requirements of an obturating material. But all these materials in time has failed. What is the ideal requirements of an obturating material? That is given in the textbook. I would not go into the details of these ideal root canal materials requirements, but what we all know that what we want an obturating material which has to be radio opaque, bactericidal, at least, which should not irritate the periapical tissue, which can be easily removed. To make this job easier, today a lot of materials are available in the market. So I've categorized them into 4 different categories, which is solid core material, semi-solid core material, carrier-based, and the newer material. So let's start with the first group of obturating material, that is a solid core material. What do you understand by what is the first solid core material that comes to your mind? It is a silver points. Silver points were developed by Jasper in 1930s. Now this material was developed because they were more radio opaque. They were manufactured according to the standardized instruments, that is the hand files. The tip and the taper were standardized according to ISO standardized. They were easier to place in the canal. They were easier to remove from the canal. Secondly, it looked very aesthetic on the radiograph because of a higher density of radiopacity of these materials. But when it comes to retreatment, it was very difficult because of the corrosion products. This would fail a well-treated tooth. And these are nothing but a dead soft metal. So retreatment was very difficult to retrieve them. Now, thank God these are no more available nowadays. So whenever you see a silver point, that means this root canal is being done around 15 to 20 years back. Imagine, let's have a look at the cross section of a central incisor, right? Now we all know none of the canals is completely round. All the canals range from oval to oblong in shape or ribbon shape. Imagine if we put our silver points in these canals. These silver points are manufactured in cross round sections. If we put these silver points as an obturating material in these canals, what will happen to the lateral spaces around these silver points? Easily they will leak and corrode. And these corrosion products are silver sulfides, which are very much potential toxic to the periradicular tissue. To illustrate this, I came across this case, which was obturated long ago with silver points. In the process, the previous operator even fractured a silver point in the apical 1/3. So with the Stieglitz forceps, we removed the silver points which were projecting in the chamber. They were easy to pull it out. But this fragment which was fractured in the apical 1/3 was difficult to play around. I had to use ultrasonics, and it took a hell lot of time to remove that. Once they're out, you can see these corrosion products. These are signs of leakage. It means the canal is leaking. These are all signs of leakage. Coming to the next set of solid core obturating material is gutta percha. Everyone is aware they call gutta percha, some call it gutta percha. What is gutta percha? Gutta percha, if we know, is a polyisoprene crystalline structure which is derived from a natural rubber tree called Manilkara bidentata. It is available in Brazil. This leaf will undergo process, and through rigorous processing, what we get is a gutta percha, what we are using today. It is a natural rubber. Today, we are using these refined manufactured gutta percha cones which are readily available in the market. Previously, these gutta percha cones we had to customize according to the canal diameter and canal irregularities. But nowadays they have been standardized and they match the size and taper of the rotary files which we use today. It has made our job very easy. But on the other hand, we should know what are the advantages of this gutta percha. Why don't we use any other obturating material? Why only gutta percha? It is a thermoplastic material. The benefit of these gutta percha is that we can change the shape of this gutta percha when heated, and on cooling down, it settles, it hardens. Now, this gutta percha has three phases. What is alpha phase, beta phase, and the gamma phase. Whatever the gutta percha you use as a gutta percha cones which are readily available on the market are in the beta phase. When you heat this gutta percha between 42 to 45 degrees, it becomes softened up. It becomes sticky, and you can compact this gutta percha. That phase is called as the alpha phase. And when you heat the same gutta percha at a higher temperature, more than 60 to 150 degrees, it becomes more flowy, more tacky, more runny. This is the gamma phase, what we fill as the liquid or the backfill, what we call as. It is more flowy in consistency. And once it sets, it hardens to beta phase. It recrystallizes to beta phase. So that's the beauty of this gutta percha. Today, we are using a standardized cones and non-standardized cones. These are the two cones which are available in the market. What do you understand by standardized cones? Standardized cones are the ones whose tip and the taper matches to the corresponding file which you have used. Suppose you're using 2504. So the 2504 cone, the tip and the taper will match to the last file used. If you're using a 3004, it will match to the last file used, which you have used in the canal. On the other hand, the non-standardized cones, their taper and their tip diameter will not match to the rotary files which you are using, or even the manual files which you are using. So how do you convert the non-standardized cones to the standardized cones? By the use of something called as gutta gauge, a very important tool in the practice. Gutta gauge is nothing, but it is a designated tool to convert these gutta percha to the standardized cones. What this device do is there are different holes on these scale. This will determine the diameter of the gutta percha tip. Suppose you want to convert a 20 number cone to a 30 number cone, you just have to pass this cone from one side on the 30 number. The cone will come out on the other side. When you snap this cone, it will convert to a 30 number GP. So you can easily convert a non-standardized cone to a standardized one. All know we are using the materials. Gutta percha is the most common material we use, but how this gutta percha cone can be used with using different obturation techniques, let us understand this. For me, getting a proper armamentarium is utmost important, because when I schedule my patients for the obturation, I do not want to run here and there to bring plugger in place or the spreader in place. I ask my assistant to arrange everything in order so that the workflow becomes very easy. For this, you need a good set of spreaders, good set of pluggers, good endodontic rulers, and good paper points and lock-in tweezers, which I prefer the most. It makes the job easier. So let's understand the first obturation technique, what we call as the cold lateral condensation. This technique is practiced all over the world because it is taught in all the dental schools all around the world. But what I would like to bring to your notice is this a correct terminology? cold lateral condensation? What do you think? Gases condense. Gutta percha can be compacted. They cannot condense. So I would like to reframe it as cold lateral compaction, because here we are compacting gutta percha into the tight spaces, right? So get your terminology right. I've seen many clinicians use the cold lateral condensation terminology. So what are the benefits of cold lateral compaction? They're easy to use, easy to master. It has a good length control. They are easily available to the right size of the corresponding standardized instruments. Standardized, as I said, standardized gutta percha are available. So there are less chances of overfilling, and they're easy to remove when there is a chances of overfill. You just pull the gutta percha out and the whole gutta percha comes out in total. Despite of the ease of the technique, there are troubleshooting where the clinicians face during lateral compaction. What are those? There's a buckling up of the GP. There is canal due to the canal irregularities. The gutta percha is not reaching the apex. There's wrong selection of the gutta percha. Inadequate preparation. Due to all these reasons, the gutta percha is not able to reach the apex. Now, what are the causes which prevents the gutta percha to reach from the apex? First thing is irregular preparation. Probably you might have created a small micro ledge on one of the walls, and when you put your gutta percha on in the canal, it tends to go and hit that canal wall. Selecting a wrong sized gutta percha, because many a times the taper which we prepare and the taper of the gutta percha do not match. For these reasons, many times the companies, they recommend to use a corresponding company gutta percha. Whatever the company rotary files you're using, you should use the same company gutta percha so that the tip and the taper matches. Thirdly, there is variation in the file. And lastly, there could be some dentine mud which might have packed in the apical 1/3. So you need to recapitulate that so that you clear the debris and your gutta percha can reach the apical 1/3. Look at this gentleman. I do not know why the previous operator did not take a post-op X-ray. There's a broken instrument, there's inadequate obturation, that is still acceptable. But this gentleman has obturated outside in the periodontium, the periodontal ligament, and over that he has taken the crown. Wow. Always I urge the clinicians, you take multiple angle radiographs so that you get to know where you're going wrong. I do not know many clinicians, they avoid taking radiographs, but it helps at every step. In endodontics, at least 4 different angle radiographs is a must. One of the most important point in lateral compaction is tuck back. As I say, tuck back is resistance to displacement, and it should be so strong that even if you tend to dance on this, the gutta percha should not go beyond the apical confines, right? This should be tightly snug fit at the apical 1/3. Once you gain that, this will give you confidence that your gutta percha is not going to go beyond the confines of the apical 1/3. If not, you can easily, if you do not get a good tuck back, you can easily cut back the gutta percha, or you can select another size, a bigger size gutta percha, and check for the resistance or tackiness. Sometimes there could be a false tuck back due to the inadequate or irregularities in the canal, where you're using a larger tapered, sometimes you're using a larger tapered gutta percha, and due to the premature contact of this gutta percha with the canal walls, you get a false tuck back feeling. Always confirm with a radiograph where your gutta percha is going. Sometimes the gutta percha does not go the way the file goes inside the canal. You will put your number 15 or 20K files easily, but when you tend to put your gutta percha in there, it will buckle up or it will tend to bend up. So that means your preparation is not standardized. You're not given enough taper to your preparations. You go back to your preparations and try your master cone fit again. So once you have checked what are the steps involved in cold lateral compaction, what I use is sealer application. Once you have checked your master cone, there's a snug fit, you get a good tuck back, you apply the sealer in the canal with the help of a paper point. Now, why paper point? because we do not want to pool the canal with lot of sealer. We want a thin layer of sealer coating the canal walls, and I want a more volume of gutta percha in the canal than the sealer. The paper point will whip away all the excess sealer and will leave a thin film beyond. The next step is you coat the gutta percha with a small amount of sealer in the apical 1/3. You go on compacting. We all know this step. I'm just brushing through them. For those who make minor mistakes or for those who miss out on some points, we go on compacting with the plugger or spreader, so that we create lateral spaces, and we go on putting accessory cones. With an appropriate size spreader, you should have a different set of spreaders, because based on the canal anatomy, you have to select a good size set of spreaders, and you should check prior to the cone fit till what level your spreader is going. Once you have checked the master cone, you go on compacting lateral forces so that more number of gutta percha cones can be accumulated in the tight spaces of the canal, until you go on compacting these accessory cones until your spreader do not go beyond 2 mm from the orifices. That's where you are sure that you have compacted the canal well. And then you sear it off at the orifice level. We all know this technique. But what I want to highlight in this is, let us see, this looks a very beautiful obturation. There's a lateral canal which got filled up. It is right up to the radiographic apex. Now let's look at it from the different angle. When I change the angulation of the tooth, you see the same gutta percha seems to be overfilled. As I said, this is a game of the minor and the major apical diameter. It's a game of angulation. So always when you check your gutta percha cones, take a different angled radiograph to double check that your gutta percha cone is not going beyond. Confirm your working lengths with apex locators as well as radiographs. This will prevent over obturations and over instrumentations. Another matter which is of concern is the stresses applied while lateral compaction. Studies have shown by Hatton and his associates that excessive forces while lateral compacting these gutta percha into the tiny spaces create wedging effects, and that's where vertical fractures are very often observed in the cases where you apply heavy forces. Stresses up to 1.5 kg is enough to induce fracture. So we need to, these gutta percha are softened up. We do not need to apply heavy forces. With just pressure, as much pressure you apply with the pen, you just compact the gutta percha laterally, you create a space, and it is enough for accessory cones to fit in there. What are the drawbacks of cold lateral compaction technique? One of the most important thing is does not produce a homogeneous mass, because the gutta percha and the accessory cones are bonded together in a pool of sealer, and when over a period of time this sealer gets resorbed, there are voids which are left beyond, and these spaces are enough for bacteria to recolonize and fail a well-treated tooth. Too much lateral forces may cause vertical root fractures, I mentioned already. It is a similar way because all the gutta percha cones are manufactured in a round cross section. So likewise in the silver points, when we obturate with a single cone, there are a lot of lateral spaces which are left behind, and which is one of the major factors for failure of these technique, the endodontic treatment. To overcome these shortcomings, we have evolved with the advanced obturating techniques. Let us understand one by one what are these advanced obturation techniques. First one on the list is gutta flow. Gutta flow is a system available from Colteen Walden. It is a cold flowable gutta percha system. Now here, no heat is applied. This system comes with a capsule, like an amalgam capsule. This capsule has two compartments. One compartment holds gutta percha in a powdered form, and the second compartment has a liquid. Mind you, this system does not need a sealer, separate sealer, because when the powder and liquid gets mixed, that works as a sealer. So the liquid, the compartment where the liquid is present, that is actually a sealer, silicone-based sealer. So when you press these capsule, the barrier is broken, and you put this capsule in a triturator, allow it to triturate for a minute, and then you load this on the gun available in the system. And the plastic tip, you express this filling material directly inside the canal. Now, one of the drawbacks with this system, there are concerns about overfilling, pushing this obturating material beyond the confines because it is in a very flowy consistency. And if your apical foramen is wide enough, you tend to push this material very easily beyond the confines. So in order to prevent that, you need to put a master cone. This master cone will go and plug the apical foramen there, and then you can inject these cold flowable gutta percha surrounding the lateral spaces in the canal. So you can see here, this technique needs little technique sensitive, that need little practice to master. Another coming to the advanced obturation technique is the thermoplastic obturation techniques. We all know this. This technique was first described by Schiller in 1967. Now the advantage of these technique, because these can be molded, gutta percha can be heated and molded. This became a very popular technique among endodontists. It can fill irregular canals, it can fill resorption defects, wider canals, C-shaped canals, and there was a more number of gutta percha, more mass of gutta percha in the canal than the sealer. And it is again a technique sensitive, and it requires special heating devices such as these, which comes at a cost. So let us understand. First step is the warm vertical compaction. Warm vertical compaction is a technique which was originally described by Herbert Schiller. This technique involves, once you are sure that your master cone fit is appropriate, you get a good tuck back, you coat the gutta percha cone with the sealer, place it in the canal. Here, you do not need any accessory cones. With the downpack device, you apply a burst of heat at the orifice level. When you apply this heat travels down 3 millimeters down from the point where the gutta percha is seared off. Then with an appropriate size plugger, you go on compacting these gutta percha vertically down. Now with the heat, this gutta percha has softened up, and with the plugger, it adapts well to the canal walls. You go on doing this unless and until you plug the apical 5 millimeters of the canal with the gutta percha. You go on applying the burst of heat slowly down the line every 5 millimeters until apical 5 millimeters of the canal gets filled up with the warm vertical compaction. I mean the molten or the heated gutta percha. And then the rest of the canal you can fill up with a backfill. Now, why not fill the entire canal with the backfill directly? It takes 1 second to fill the entire canal with a backfill. But again, there are concerns of pushing this obturating material beyond the confines. You have to have that apical control, that once these obturating material gets pushed beyond, it's difficult to retrieve them. You have to resort to the surgery. So here's the 3-dimensional fill. You see how beautiful the canal, the obturating material is adapted. There's a lateral fill. To make you understand easier, let's have a look at this clinical scenario where after the proper master cone check and a good tuck back, I have selected this master cone. You can see from different angles. There are a lot of, this is a tear-shaped canal. You can see it is an oval canal. So if you put a single cone here, there are a lot of lateral spaces around the canal, which can be easily colonized. So we apply here, we dry the canal with paper point, we apply the sealer coatings, and with the heat stroke, we soften the gutta percha at the orifice level. And with the appropriate size plugger, I go on compacting this gutta percha apically. And here you see at a higher magnification how well the gutta percha is adapted to the canal walls. Now I'm sure there are less chances of micro leakage here. The rest of the canal I can backfill with the flowable gutta percha or the backfill unit, such as Obtura. Let us look at this case. Very interesting. As I always say, the premolars are notorious. This case walked into my clinic with a carious premolar. When we attempted to treat this endodontically, when I put in my files there for the working length, I sensed that this anatomy is not the regular anatomy. The way my files were going, my gada pacha was not going the same way. So I was sure that I am going to miss out on some anatomies out here. So I went back to my downpack and backfill technique. And here you see the post-op. You see the canal is dividing into the two, and there was an anastomosing canal. There was another canal which is being overlapped behind, which I had missed, and they were connecting with each other, which got filled up with the thermoplastic obturation. This is the thrill of the fill. As I say, there's always a disadvantages. Every coin has two sides. There are also disadvantages with this technique as well. This is a technique sensitive. You need to master this technique on an extracted teeth before using on patients. There are always chances of overfilling. If you tend to overfill these flowable gada percha beyond the confines, no way you can retrieve with H files or any material. You have to do apical surgery, right? There are also concerns of vertical root fracture from compacting. You have to be very careful. You do not have to apply a lot of forces because this creates wedging forces. Pluggers will cause lateral forces on the walls of the root because the roots are in a tapered preparation. And our gada percha, our pluggers have a flat end. So there are forces which act on the lateral walls and which will cause vertical fracture. And there are also concerns about intracanal temperature rise. Well, there are many studies which raise the concerns about the intracanal temperature rise, which will affect the periodontium in turn. But all these studies are being done in vivo, in vitro. In vivo, that means in the patient's mouth. Our tooth is surrounded by saliva and all that blood circulation. So the temperature cools down at a rapid rate. So there are less chances of periodontium gets affected by the heated gada percha techniques. Now let's have a look at a higher magnification, the cross section of the cold lateral compaction and the warm vertical compaction technique here. What you see on the left, this is a master cone, and what you see, the yellow part is the sealer. And can you see there's a void in here? Now these voids are not appreciated on a radiograph because it's a 2D image of a 3D object. On the other hand, with a warm vertical compaction technique, the gada percha is very well adapted to the canal walls. To the latest materials, what we call as bioactive materials. What do you understand by bioactivity? Bioactivity is defined as an ability of a material to elicit a healing response in the neighboring tissue. Bioactive, what we understand by this term, it is a material which releases ions which are active and which brings about a healing environment around the tissue. And we very well know this was first introduced by Mahmoud Torabijanath in 1993, what we today we know as MTA, mineral trioxide aggregate. Now, this material was first introduced as a root and filling material for apicectomy or the retrograde filling material for endodontic surgeries. But because of its excellent healing ability, this material was used in multiple reasons, in multiple conditions such as perforation repair, in apexogenesis, apexifications, as well as obturating materials. You see here, we all might have come across wide open blunderbuss apices, a lot of trauma cases which later on come to you after 15 years, and you are always perplexed how to go about such cases and how to bring about a good coronal seal. Thanks to Dr. Mahmoud Torabijanath, this material is a boon in dentistry. As you can see here, if this material, even if it gets pushed slightly beyond, it is bringing about a healing environment. So there is no fear of pushing this material. But yes, you have to be within the confines of the endodontic guidelines. What you see here is apical 5 millimeters is filled with MTA, and then middle third is filled with gada percha, and then composite over them. Now I know the next question which arises in your mind is, why not fill the entire canal with MTA? Well, the answer to that is If you are a rich dentist, you may. But on the other hand, jokes apart, if you need to put a post-end core in an anterior tooth, you need to leave that space behind. So you plan your endodontic procedure well in advance, because removing that MTA from the canal is a very tough job. It's a rock solid to bang your head against it. Now this material has helped me in cases scenarios like this. Look at this, an internal severe internal resorption, internal as well as external. When we look at this case through CBCT, you see there's an external as well as internal resorption through and through, from buccal to palatal. Now, what would you do in such scenario? Definitely, any dentist would advise extraction in this scenario, but patient was willing to save this tooth since she was, a very young patient and wanted to save her front teeth. So we went ahead, we attempted this, we cleaned and debrided the canal thoroughly, we packed MTA. We say the apical 5 millimeters of the canal is completely blocked. So there was due to the resorption. Now this duration seems to be slightly short, but when we took a post-op CBCT, you see it is filled in 3-dimensionally. So now I'm damn sure that this lesion will heal. I've asked the patient to come after a year. She stays in Canada. So follow-up will bring about good results, which I wouldn't have been able to treat this case with gutta percha probably, thanks to the latest materials. Another beautiful material available in the market is biodentine. It is a similar as MTA. It is also a dicalcium, tricalcium silicate. Now, the disadvantage of MTA is that it takes 3 hours to set. So we cannot carry out endodontic procedures in single visit. Whereas the biodentine, due to addition of calcium chloride, which works as an accelerator, this sets the initial setting time of biodentine is between 12 to 15 minutes. That means we can carry out an endodontic procedures in a single visit. You see, the similar case as before. I have a lot of such cases with an open apices. I choose my material based on case to case. It also depends on how far the patient is coming, because many times it's impossible for patient to travel from a longer distance and come again and again. So in such cases, biodentine works wonders. So here again, the apical 1/3 has been plugged with biodentine. You will see the radio opacity of biodentine is less compared to MTA. That's okay. And the same way, middle third is packed with gutta percha and the coronal is packed with composite. How do you carry these MTA and biodentine in the apical 1/3? Because there is no apical control zone. This is a very technique sensitive method. First and foremost, you have to determine an accurate working length. Once you have determined that, keep your instrumentation at least 2 millimeters short of the apex. You need a micro-apical placement device, MAP1, which is available in the market. This is a precise device where you can precisely place your MTA or biodentine in precise increments to whatever level, and you go on compacting with an appropriate size plugger until your apical 5 mm is packed with MTA, or you can fill the entire canal with MTA. For in this example, now this, how I decide whether I should pack the entire canal with MTA or I should plug only the apical 5 mm. It depends how much of the coronal tooth structure is left out behind. If I'm planning the post-end core, I will only plug the apical 5 mm. But if I have a good coronal structure, I go on placing these MTA or biodentine in an increment wise and go on packing them and adapting them under the microscope towards the canal so that there are no lateral spaces. To a most recent obturation scenarios, it is a very controversial scenario. Single cone obturation technique is not a new technique. It is a very old time technique, but it has been revised and revisited nowadays due to these bioceramic sealers. Nowadays, a lot of bioceramic sealers are available on the market. These sealers are nothing but a product of bioactive materials derived from dicalcium calcium silicate, that is MTA or biodentine, but in a very flowable consistency. Definitely, it makes our job very easy. We just need to push these materials and put a single cone and obturate at the orifice level. It makes your job very easy. But studies have shown this material tends to flow in the intricacies around the gutta percha. Are these materials uh, dimensionally stable? We do not know. What is one of the ideal requirements for the root canal filling materials, even the sealers, is the material, whatever we put inside the canal, need to be dimensionally stable. That means over a period of time, they should not resolve. They should stay there and as it is so that it prevents micro leakage. Now, definitely, these bioceramic sealers are a boon in dentistry because it brings about a beautiful healing uh, in the periradicular region due to its dicalcium, tricalcium minerals and a healing potential. It brings about an osteoblastic, odontoblastic activity. But a lot of studies are going underway to bring about to study in what all microorganisms this is active against. As you can see, I have used here a bioceramic sealer which has flown in well into the lateral canals. Here my obturation again is my gutta percha is right up till here. Whatever has flown in the lateral intricacies are my sealer. But how dimensionally stable these sealers are, we do not know. Only time will tell. Because time and again, many sealers over a period of time, they resolve and they leave behind voids. So far, a lot of studies are under process and they have shown that most of these bioceramic sealers are effective as a might and brings about a healing potential and has an antimicrobial efficacy against E. faecalis and other microorganisms, which is a mixed infection in the root canal disease. Guys, with this, I know there's a lot more to speak about obturation, but considering the time frame which has been allotted, I have highlighted the main points, highlighted points in our what we miss around in our obturation systems or techniques, which are which we practice in our day-to-day daily routine dentistry, but we miss out on one or other points which makes a difference. So I wish you a very good healing, a very good endodontics. And I have been carrying, if you respect the anatomy well, the tooth will give you rewards in turn. So do not violate the endodontic guidelines. Be within the confines of the endodontic guidelines. And with this, I end my presentation. I've been conducting endodontic workshops. Any one of you are interested, you can contact me via Facebook or Instagram. If we go into the detail of this obturation technique, we can go on for next 2 hours and 3 hours. But looking to the time frame, I think I have to take a lot of question and answers. So I have highlighted the main points and key features in my presentation. I thank you all for being a wonderful audience.
Thank you, Dr. Harsh. It was a wonderful presentation. And now I welcome Dr. Urshita Jikar Wadia as today's guest moderator. And Dr. Urshita has done her BDS and MDS both from Nadiad, and she's a practicing endodontist in Vadodara for the last 7 years. So welcome, Dr. Urshita, and now we'll start with the question and answer session. And off late, you have started taking guest moderators belonging to the same domain as that of the guest speaker so that they can add more value to the discussion and make the question and answer session more interesting. So, Dr. Harsh, you can stop sharing the presentation.
Okay, sir. Shall I stop sharing the screen, sir?
Yeah. Click on stop share. Bas. Good enough. So I request the audience, if you have any questions, type in the chat box. If you want to talk to Dr. Harsh, please raise your hand. I'll give you the permission to talk with video. Before we start with the live questions, we would like to ask some of the questions sent by our registered delegates. Most of the questions that we have received have already been answered by Dr. Harsh in his lecture. Yet I will be reading them, and Dr. Harsh and Dr. Urshita can decide whether to take up that question or leave it. Is there any specific advice you want to give for obturation with bioceramic sealer? I know you have covered it, but if you can just describe it in one line, it will be great.
The latest single cone technique, what people are using, I'm not an ardent fan of single cone obturation because I do not know the bioceramic sealer's biostability. If it resolves over a period of time, only time will tell whether this sealer is dimensionally stable or it's resolving. So if you are using bioceramic sealer, you can always use the your basic techniques such as cold lateral compaction or warm vertical compaction as well. So we make sure.
I'd like to add that I've been using the CeraSeal since the past 2 years now, 1.5, 2 years. And before that, I used to use AH+. So that was a resin-based sealer. So what I have noticed is, first of all, the ease of placing it in the canal with the bioceramic, because they give us a tip. There's a lot of wastage, let me add. First, it's very expensive. Second, there's a lot of wastage because it has a tip, a long tip. So basically, the material that goes in the tip is basically wasted. You will not be able to retrieve it. So apart from these two disadvantages, the flow is phenomenal. There have been times where I've been able to only probably not get the glide path till the working length and only I'm 2 or 3 mm short. But rest assured, if I stick to my irrigation protocol, the sealer will go through and reach the apex. So that is one beautiful nature of the bioceramic sealer that I've not seen in any other sealer till now.
Yes, it makes your job a little easier. And one more plus point about bioceramic I have observed is minimal post-op pain. Where with other sealers, resin sealers, or even calcium hydroxide based sealers, patients tend to have post-op pain. Bioceramics are not.
But the resin, the AH+, I think I've seen cases where 5-6 years later, the sealer puff remains untouched.
Yeah.
I mean, it's just insoluble in the periapicalization.
Yes, AH+ never resolves.
Will not resolve. Yes.
Ever. And if you have
other problem with the packaging, there's a lot of problem with the AH+ packaging. I don't know if it's just me or it happens to other people also, that it starts to leak after a certain point. So again, it's an expensive sealer, but half of it is wasted in just leaking. And then, so there are some advantages and disadvantages. Whatever works best for you, you have to work it out.
As I say, every material or every technique has plus points, minus points. AH+ has an excellent flow, excellent radiopacity. But yes, it has an initial toxicity for 72 hours post-op pain. Whereas bioceramic sealers, they do not cause any post-op pain, but are they dimensionally stable? I will get to know in the follow-ups for the patients when they turn up.
So you were going to address the fact whether these sealer puffs are good or bad. You said you will come to it later.
Yeah, sealer puffs, there's two schools of thought. One school of thought says that sealer puffs are good so that they seal the apical foramen, so there's less chances of leakage from the apical 1/3. But there's a second school of thought. It's a very controversial topic. There's a second school of thought which believes that anything should not be pushed beyond the confines. You should stay within the confines of the endodontic canals. As I mentioned, we have to remain within the confines of the minor apical diameter. As we discussed now, if we push any resin sealer beyond, it gives a very good radiographic appearance, but it gives a post-op pain. If it doesn't resolve, definitely it is going to affect the patient in the long run. So it is a very controversial debate. There's no any specific thumb rule whether you should push or no. But I do not. I've seen many clinicians who pump the GP so that they get an apical puffs. In my clinical scenarios, I do not tend to get those puffs. If they get filled up, that's fine with thermoplastic obturation. But I do not, strive to get those puffs intentionally.
It happens. Otherwise, it's not necessary that it should.
Yes. Exactly.
it's always reassuring to know when the puff is there. I mean, you are reassured that you've done something right.
Puffs are good aesthetically on radiographs, frankly speaking. It has nothing to do with any healing potential. If you're confident enough, you have cleaned the canal well, you have shaped them well, you have packed them well, healing is going to occur. So puffs are
Remove the foci of infection and do the needful, it is going to work.
Yeah, because see, at a histologic level, it is going to bring about inflammatory change.
Foreign body reaction in the periapical tissue.
So better not to push. Don't tend to push sealer beyond. If it flows, fine, but don't pump the sealer beyond the apical constriction. Right? I hope that clears it.
That was a great point. I think the practitioners who wanted to know about it must have noted down the point. And let us take some of the questions sent by the live audience. Kindly describe the minor and major diameter of root apex. If you have already described it in the lecture, you need not go in detail.
Yes, I've already covered that diagrammatically. So I hope the attendee has that concept clear in mind. Sir, there are other set of questions which I might go across. I think the registered delegates.
Yeah, please.
How to have obturation bioceramic sealer? I mentioned that you can obturate either with lateral compaction, with thermoplastic. Both works with bioceramic. One of the very common question, which is the most effective sealer? Well, for me, the sealer is secondary. Sealer is just as a lubricant, or sealer is used to fill those intricacies where your gutta percha does not go. So for me, sealer is not that important. For me, cleaning the canals well and obturating them well is what matters. Previously, zinc oxide sealers were used. Still, we have seen tremendous healing and good cases with the good follow-ups. So sealers are something secondary for me. Another good question, how to sterilize gutta percha points? Very interesting question. Yes, whatever you put inside the canal has to be sterilized. I sterilize my gutta percha points either by placing them in chlorhexidine, or you can even put them in sodium hypochlorite, full strength sodium hypochlorite. But after you put them in sodium hypochlorite, you make sure you put them in saline, because when the gutta percha dries up, there are salt deposits on the gutta percha that will microscopically hamper.
Topography is altered, and you must, I mean, the monoblock concept is not achieved in case there are discrepancies on the gutta percha.
Exactly.
So it's always better. But yes, sterilization of gutta percha is a must. More important than, I think, sterilizing files, because that's going to be the last material that you will be placing in the canal. So most people tend to avoid it. And yes, I mean, it is important. You have to place it in full, like sir said, full strength sodium hypochlorite, and then wash it off with either distilled water, spirit, or saline, depending on whatever is available or whatever works for you.
There is a very relevant question from the audience. Failure of root canal in several years despite proper obturation. Now, at every step, where have you gone wrong? Nobody knows. Whether you have sterilized your instruments, whether you have sterilized your gutta percha, whether you have cleaned the canal well, irrigated the canal well. At every step, it's like a snake and ladder. If you have missed out on something, you will see failures. So you do not know, and it is very difficult to judge right from looking at the X-ray.
Sir, but I would like to add that first of all, an X-ray is by no means a short way of judging whether the tooth is done properly, because like sir said, it's a 2D, 3D, 2D image of a 3D object. So even a CBCT sometimes can not tell us whether the root canal was done properly or not, just because there was no periapical. I'm treating a few cases right now where there is no periapical lesion even on the CBCT. But as soon as you remove the crown for some other reasons, there's a pungent smell, an odor coming from the tooth, which means that there is some infection brewing. So I'd like to add that patient immunity also is a major factor in knowing whether the tooth will do well or how long the tooth will last or the prognosis. Because badly done root canals last lifetimes sometimes, and a beautifully done root canal can fail in a year or two. So it's very difficult, but patient immunity also is a major factor.
Yeah. See, if you ask me to list down the reasons of endodontic failures, there's 100 reasons why endodontic fail. You are correct on your part. Immunity does play. I have come across my patient who has had high diabetes and his periapical lesion was not healing. So that also attributes to overall the medical condition of the patient, also attributes to the failure. But as you said, when you remove the crown, a pungent smell is a sign of leakage below the crown. Now, if your coronal restoration is not done properly, or if there is a leakage from the coronal structure, that is one of the reasons where your pungent smell. It is not attributed to immunity. Definitely, immunity will play.
What I meant was immunity is a completely different topic. This is just me saying that
One
sometimes a stable tooth suddenly becomes symptomatic, say after 10 or 15 years. Why does that happen? Because
it's a micro leakage over a period of time, over a period of 15 years. I have come across numerous cases where even when I've removed the crown. Now, one of the main causes is composites. I know most of the clinicians they
have a particular stench when
they absorb these saliva or these chromogenic stains, and composites they because of the polymerization shrinkage, there are higher chances of micro leakage. Now, the second question relevant to this is, which is the best post endodontic material after obturation so that leakage does not occur, right? Well, I would recommend the core built-up materials. They have less shrinkage compared to a regular composites. What most of the clinicians, they're using these Chinese or the cheaper composites to cut off the cost. But over a period of time, I've seen those composites, they shrink. They have a shrinkage of more than 5%, and that's is one of the major causes of failure. Second, good post-endodontic restorative material is an old material, which we all know is amalgam. But amalgam also leaks. I do not deny. Every material has a leakage, but we have to select which material has the least leakage. Now, amalgam has one good property, is self-sealing property. Over a period of time, due to the leakage, there are corrosion products which are formed in the interface between the amalgam and the cavo surface margin. And these corrosion products will tighten the seal. But on the other hand, amalgam tends to create a lot of microfractures beneath the crowns. So when you remove these amalgams, you will see a lot of cracks in the chamber. So I would like a material which bonds to the tooth well, and at the same time, it shrinks less. So I prefer the core build-up materials, such as Luxa core, Paracore. All these materials are beautiful. Then, am I audible?
Yeah.
Yes, yes.
Then there is how to avoid over preparation. I think the minor or the major apical diameter, the apical control zone, says it all. I have seen sealer puffs. I think I've addressed that. Which sealer is best for me? Every sealer works. It's the technique which matters. How to understand that GP has received the exact point, not short nor excess? Good question. Well, I already mentioned this in my presentation. I would like to address once again. There are 2-3 ways where you can check your GP is right up to the apex. First of all, you can use the paper point technique. You put your paper point after you thoroughly dried the canal well. You take a sterile paper point, put it and see if your apical 0.5 or 1 millimeter of your paper point is getting wet or soaked with blood. Just put that paper point in close approximation to the gutta percha point. So that means you're going slightly beyond the minor apical diameter. So cut your gutta percha till that level and take a radiograph once again. Second thing, after you have second way where you can determine this is after you have shaped your canal well, you have dried your canal well, you're ready to obturate. once again, just one more time, put your endodontic file in there and use an apex locator to confirm the working length. Once you're sure with the apex locator, to that level, put your gadapacha cone and check radiographically. These two techniques will prevent you from, over preparations or over obturations, over place.
There is a similar question in the from the live audience.
Yes, sir.
Which is the best sealer, and is it safe if it gets leached out of the canal into periapical areas? I think you have already discussed it in great detail.
Sir, already discussed that.
Yeah.
What is the difference between bioceramic seal and resin base? We discussed that. Apex locator reading 00, it means apex, how much short we have to keep it. Now this depends on what brand apex locator you're using. There are a number of apex locators available on the market. What I would recommend would be J Morita. It has a 96% accuracy. So I blindly trust my apex locator. There are other apex locators, but it has given me consistent results. J Morita. But if you're using any other apex locators, there are apex locators available in the market where at 00, they show 00 reading, but when you tend to take a radiograph, actually the gadapacha is beyond. So you have to cut 0.5, 1 mm from that point. So different apex locators, there are 7 generations of apex locators. It's a in-depth another topic in itself. So based on what generation apex locator you're using. Your view about use of reciprocating handpiece for K-files in routine dentistry? Well, I use reciprocating handpiece only as a means of a glide path preparation, not for preparing the canal or shaping the canal, because there are 2 points. Once when you take your K-file right up to the apical foramen and you reciprocate at a very high speed, most of your reciprocating handpieces are attached to your chair side, attachments, which rotates at a very high speed of around 30,000 RPMs. So at such a high speed, you tend to transport the apical foramen, or you rip off the apical foramen. So you are violating, you strip sometimes you create an additional foramen. So when a file rotates at a 30,000 RPM at a reciprocating mode, so it rips off the apical foramen. So you can use smaller number files such as 10 number file with your reciprocating handpiece for that, not for the bigger files. The more bigger files will transport the canal. Okay. How to identify cracked tooth initially as the symptoms are not localized? For crack determination, as I mentioned earlier, here when we are dealing with a 2D image of a 3D object. So to determine if the crack is there, there are 2 ways. Either you can locate it under high magnification. That is also not sure and sure. If the crack is in the chamber or in the coronal one, that you will be able to locate it under higher magnification with microscope. And the second way is through CBCT. Sometimes even CBCT is not 100% reliable. Sometimes they miss out. But these are the 2 ways where you can determine the crack. Then there are other ways where you can put your methylene ice and leave it for a minute and then wash it with saline. So the dyes will stain the crack. That will help you in localizing the crack.
Clinically, there's one feature that really sets it apart is sharp shooting pain in an otherwise normal tooth. I mean, you will not be able to see any other disease in that tooth, but severe sharp shooting pain. And sometimes what I do is, and usually that is what I do. I try and explore the crack that I feel, and 100% of the times it's communicating with the pulp. So like an exploratory or maybe anesthesia to check which jaw is the one where the tooth is. So anesthetic testing, exploratory tooth preparation.
Yes.
These are some other ways, but then you have to it needs experience. You can't just jump into just preparing a tooth.
It's difficult to diagnose cracks.
Yes, it is
because there's something called as cracked tooth syndrome. It is a combination
the most difficult actually to diagnose.
There is something called as bite test, then something called as probing test. All these tests help you. They will give you.
But if you're able to get it right, then that patient is yours for life. That's what I've noticed. They think you're God. because
yes.
yeah.
It is very difficult to diagnose
Yeah,
cracks.
because there are so many patients who come after visiting so many other dentists and they all say, oh, there's nothing wrong with your tooth, because it's not even necrotic. The pulp is not necrotic that the patient the no dentist is usually able to tell. So it's usually, yeah, if you get it right, you get it right. It's like that.
It's one of the challenging diagnoses in endodontics.
True.
So I think that I've covered whatever the participants.
Yeah, registered delegates questions.
Registered
Now we'll
delegate.
take up the live questions.
Yes, sir.
The first two questions you have already answered: minor and major diameters of root apex, and second is which is the best sealer. Next question is, while placing GP coated with sealer, do we need to wait for a few minutes with GP inside canal before we cut the GP?
No need. Why want to wait? Because sealer takes minimum its time to set. So for example, bioceramic sets in approximately 2 or 3 hours, and resin sealer such as AH plus will take 24 hours to set, 24 to 48 hours to set. So you need not have to wait. You can just sear off the GP.
The more you wait, the more you are letting your tooth get contaminated by biofilms. Again, biofilm is like a whole new topic that one can cover. But yes, you shouldn't be waiting unnecessarily.
No, but waiting does not make any sense. Why you want to wait?
Yes,
you have cleaned it, you have dried the canal, you just fill it up.
Can we place MTA in apex in tooth with periapical lesions, and rest of the canal can be obturated with zinc oxide eugenol based sealer?
Why a zinc oxide? You can use, yes, very much. You can obturate the canal with a periapical lesion. Definitely, it gives beautiful healing the periapical region. I have number of cases seen, and my colleagues also have beautiful cases documented. Then why you want to fill the rest of the canal with zinc oxide eugenol? You can use a bioceramic sealer. It gels well with MT because they are the same family. They're from the same family. So I would recommend to use a bioceramic sealer along with MTA. That works better. That combination works better because eugenol, you never know, eugenol might interfere in the setting of MTA.
Great. Why does a tooth become tender after obturation?
Because you have pushed your irrigants, your sealers beyond the confines, you have over-instrumented the canals. One of the very common reasons of post-obturation pain. It is a foreign body reaction, periapical inflammations.
Inflammatory process that follows.
That's why I always stress upon to be in the confines of the canals.
Okay.
One more thing, there are some people who get really worked up, some clinicians, after the patients complain of post-op pain after obturation or even calcium hydroxide placement. So that's where I would like to add that a day or two post-op pain is normal. You don't need to worry about it. Some people try and retrieve their GP saying that, oh, there's something wrong, I need to work, do something about it. I feel that a day or two post-op with analgesics is okay, nothing to worry about. It will come along. It will come along. I mean, I don't think you need to worry about it unless there's some other big problem that some iatrogenic error that you are missing. But other than that, post-op pain is very subjective, and I don't think you need to worry about it.
It's an inflammation which subsides over a period of time.
What is your opinion on fixed taper and variable taper? Which one is better?
Sir, again, a very good question, tricky question. It depends on case to case. If I am attempting a normal canals, I mean a normal anatomy, like straightforward taper, straightforward molar, fixed taper. But if I have, I'm attempting a very narrow or tortuous canal, I might go up to variable taper. So I decide on case to case what file system I'm supposed to use. Like how we plan, sir, in implant dentistry, we plan our cases well in advance. So I spend 5 minutes looking at the X-ray. I see the number of canals. I see the canal width, how narrow the canals are, any curvature in the canals. It gives a lot of information. So you can plan it, choose your instruments accordingly.
Okay. So if you want to give them one simple rule before you start the treatment, how you will plan, how you will choose which taper, what will be that simple rule they can follow?
What I've observed with the fixed taper preparations, there are incidences of a lot of vertical root fractures because we are removing a lot of dentine. So I would ask the audience, or especially the beginners, to go for a variable taper. Nowadays, with time we are decreasing our preparations over a period of time. The more amount of dentine we are removing, more harm we are causing to the tooth. So the pericervical dentin (PCD) is what is most
Remaining
important.
dentin thickness. Yeah.
It is a major factor in a successful outcome. A very interesting fact, sir. All of us, since so many audiences are live, most of them might have seen the cases where 20-25 years back, with manual files, they used to obturate 2% GP cones and they used to use only hand files. Those cases used to last for years, maybe 15, 20, 30 years. And today with the modern endodontics, we are doing wonderful obturations. We are filling lateral canals, but we are not paying attention to the amount of dentine we are removing. And we see a lot of vertical root fractures. So it is a matter of concern. We should reduce our tapers and we should focus on preserving the pericervical dentine as much as possible.
Important point. Next question. We dry the canals properly, but after obturation there is pain and we retrieve the GP and we see bleeding inside. How to address this issue?
So once again, we dry the canals properly.
We dry the canals properly, but after obturation there is pain, and when we retrieve the GP, we see bleeding inside. Means
So
why do we see bleeding even after drying so much?
The game of minor and the major apical diameter. We are always we always work to obturate till the radiographic apex. Actually, the gutta percha, when you dried the canal, you got a good dry canal, but when you're pushing the gutta percha, you tend to push the gutta percha beyond and you don't realize. As I mentioned in one of the slides, due to the overlapping of gutta percha with the root end tip, we think that it is right up to the apex, but actually it's beyond. So that gutta percha which has been pushed beyond induces bleeding and post-op pain sometimes. Though gutta percha itself is an inert material, but if there is a periapical inflammation, it aggravates the inflammation sometimes.
Dr. Sujata has put a X-ray in IOPA. She's asking if the second molar can have 2 into 1. I'll tell you honestly, sir, you please.
No. I am not able to see the X-ray in the chat box.
Yeah.
Yeah, open the chat box.
Harsh sir, correct me if I'm wrong.
No,
More
please.
often than not, you're missing a canal here, Dr. Sujata. I mean, I have not come across a second molar where there is 2 canals converging into 1. I mean, either there are 2 separate canals, usually are 2, and there's a pesky little distal always converging like this on the radiograph. That's what I feel. What do you have to say, sir?
Yes, there are higher chances of missed canal. You are right, Dr. Urshita.
Distobuccal canal is usually, sometimes it's placed very close to the mesiobuccal, and that's why you tend to ignore it.
Yeah,
so you need to trough a little more, use ultrasonics, use magnification, irrigate, and then dentinal map, and you will more often not
find the missed canal. Surely you will find. You take different
and also one more thing is the direction of your file when you're trying to negotiate that canal. If you're going straight, then you will miss the canal and you will not go in. It's usually the angle in which you are placing it in the distal. Distals are very pesky. And if you think that there are 2 canals, then you're missing one. That's what usually happens. And then if you keep looking, you will find that 3rd canal. So that's
yeah, she's very much right. But be a little careful not to perforate. And
yes, of course.
You have to take different angle X-ray, take mesial distal, so you will get a clear picture. Still, if you're confused, you can go for a CBCT to appreciate the
verify. Yeah.
But what Dr. Urshita said, very much right. I follow the same thing. With ultrasonic, there's a precise cutting and you will uncover that hidden canal. There are high chances that you have missed a canal there.
You see this question on the screen?
So warm vertical compaction using bioceramic sealer is possible? Yes.
Yeah.
It's possible. I am doing that, warm vertical. The only thing is with heat, bioceramic sealer sets a little bit faster. So the point where your bioceramic sealer comes in contact with heat, it sets at a faster rate. So I've used that, so you have to be a little fast in your warm vertical technique. Any other live questions?
Your protocol for obturation, you have already described it in detail. You have shown cases also. If you want to add a few points on this.
My it's not different what I practice. I've shown it in my presentation, but I make sure that I get a dry canal. I do not have the post-op pain. If there's a slight bit of pain, I postpone my appointment because I know I do mostly warm vertical compaction. It is like corking a bottle. It is like when you put a pressure inside the canal and you cork it from the top. Definitely there is intracanal pressure which is going to arise, and definitely patients are going to have a little post-op pain. So my protocol is I dry the canal. My last irrigant in the canal is after sodium hypochlorite is saline, so as to wash off all the salts. Previously, with the periapical lesions, I used to use chlorhexidine, but no more now. There's no additional benefit if you're using a full strength sodium hypochlorite, your lesion will heal. The last irrigant is saline. After saline, I use EDTA for 1 minute.
EDTA.
EDTA. And again, after EDTA, I use saline so as to wash off all the acidic content from the canal. I want a neutralized environment inside my canal. And once I get a dry canal, I check my snug fit Gadapacha cone and check it if I'm confident enough. I do not check it radiographically because I rely on my apex locators. But if I'm in doubt, I definitely take X-rays and I go on obturating with warm vertical obturations, step by step. First down pack and backfill with obtura.
Okay. Can you read this? In anterior teeth, also use single cone using.
In anterior tooth, I never use single cone because anterior teeth are the widest and they're oval. They're they're broadest. They're broader in the buccolingual manner, right? So they're very much irregular. They may be oval, they may be oblong. So as I mentioned, if I put a single cone, there are a lot of lateral spaces. So if you do not have warm vertical obturation devices, you obturate with lateral compaction. But use multiple cones, use as much of, I want more volume of gutta-percha inside the canal than sealer. In bioceramic sealer, people are using more volume of a sealer than gutta-percha. It's a reverse scenario. It makes it life easy. But we do not know over a period of time the bioceramic sealer resolves or not. Only time will tell over a period of 8-10 years. So I do not want to take that chance. So I put as much gadapacha cones as much I can in central incisors, or if warm vertical obturations.
Okay.
Apex locator reading 0, how much short we have to keep our GP? 0.5 mm.
Okay. If a file breaks in apical third and then we use biotin to fill it, will that work or fail eventually?
See, it's biodentine is not going to go around the file and clean that space. If you have not cleaned the canal and the file breaks before your shipping protocols, definitely it's going to fail no matter what you do.
It depends on the time at which the file breaks.
File breaks.
Yes.
If the file has broken after you shape the canal well, you have irrigated well, then even if you obturate with gadapacha, even ZOA sealer, it will not fail. I'm not guaranteeing it will not fail. It can fail, but chances will be
are less.
yes, because it's canal which has to be cleaned before the file breaks. So biodentin is not a magic material.
Can you suggest any good company for downpack and backfill system? You
Yes.
can give some criteria or any the one you are using and finding useful.
Lot of systems are available. I'm using System B from Sabron Endo, but Sabron Endo is no more available in India. So you can go with ENQ Plus, a very good system from Meta Biomed, and I think Meta Biomed, right, Urshita? They're from Meta ENQ. ENQ Plus.
Another, they do. I don't know if they make it any. But it was Calamus by Dentsply. I used it for 5 years where I used to practice
Wonderful.
before.
Yes, I think that is also not available right now.
Not anymore.
BNL is available. BNL is a good system. You can procure it. BNL is a good system.
Okay. How can we decide? Yeah.
That our cleaning and shaping is completed. There is no deciding or thumb rule that your cleaning and shaping is finished. Well, if you are using a microscope or higher magnification, definitely you will see the minute details which a normal dentist cannot see. Because the more you see, the more time you spend in cleaning that canal, right? We are all working blindly in the tiny canal, so we do not know even a small fragment of tissue is attached. There's a fibrotic tissue sometimes which is attached to the wall, and we fail to remove that, and that is enough to call a failure. But under higher magnification, I make sure, since I'm using a magnification, I make sure even in retreatments, not a speck of GP or a sealer is there, because I can see better, I can clean the canal better. But for others, you can,
tactile, sir, because necrotic and sorry, the question's popping up. When you touch a clean canal, you get a different tactile, and when you're touching a canal full of debris, the feel is also different.
But in a necrotic, sometimes you don't feel that, and you go on widening the canal to unacceptable level. That's where you're removing a lot of dentine.
Yes.
So you have to gauge the diameter from the radiograph, and you have to plan to what level you have to widen the canal. Overzealous instrumentation is another, causes of failure, iatrogenic failure in the later stages, not immediate. So I think that helps you.
Okay. How to confirm tuck back?
I think I mentioned this in the lecture, sir.
Yeah.
Once tuck back is when you put your gutta percha cone inside the canal, you feel a strong resistance. Remove the gutta percha, you feel strong resistance. That could be a false tuck back as well, as I said, because nowadays what happens is we are using one system rotary files and we are using another company's gutta percha cone. So sometimes the taper and the taper does not match to the rotary files. So that gives a false tuck back result. But if you're sure you're using the same thing, it is a resistance to displacement. You will feel a strong resistance when you are trying to remove that gutta percha. As I said, when you put a gutta percha inside the canal, you tap it from the mirror handle or with the tweezer, so that the gutta percha, there's something called as gauging of the apical terminus. Gauging can be done with gutta percha, or you can gauge the canals with K files also. What gauging means is, after you prepare the canal to 2504, you put a 2502 file in the canal, hand files, and tap it from the with the butt end of the file with the mirror or your tweezer. If the file goes beyond the apical confine, that means your apical diameter is wider than 25 number file size. Same you can do it with the GP cone. If the gutta percha cone, you're tapping on the cone, and if it is going beyond, that means you need to prepare the canal one step further. You need to go to 3004 or 3006. Again, check for the apical gauging. Once you get a good snug fit or tuck back, at the proper working and check it with the radiograph, and that confirms your good tuck back. You're at the right length.
Okay, there is Dr. Parag who wants to ask a question. Dr. Parag, I have given you the right to speak with camera. You can speak, or you can just use audio. Your choice. Do you have a question to ask? You raised your hand.
Can you hear me, sir?
Yeah, very well.
Yes, clearly.
I've already asked the questions in the chat box question answer segment. The medicament types and indications, sealer types and indications, MB2 calcified canal identification, scouting and negotiation, lateral canal identification with IOPA, current file systems and their indication, advantages and disadvantages, and phantom pain after root canal. I want to know about this all.
Sir, can you go one by one? A lot of questions.
Yeah.
I'll
All
answer
he's
one
asking
line.
is medicament types and indications. Intracanal medicament.
First question is intracanal medicaments. Yeah, there are, the most commonly used is calcium hydroxide. I use calcium hydroxide. There are other medicaments which I would like to use, depend on the case, is a triple antibiotic paste. I mix these minocycline, tetracycline, and minoxidil, minocycline, tetracycline, and metronidazole, ciprofloxacin. I remove the enteric coating from the tablets. I crush the tablet, make it in a powder form, and mix it with the saline, and I just put it inside the canal and plug it like how I put my MTA. So
I'd like to add that making triple antibiotic paste is actually more difficult than it looks, because it has to be done in a 1:1:1 ratio, and the tablets that are available in the market are not in the same ratio. Another thing is addition of a vehicle and then placing it into the canal. So all this makes it during my PG days used to use a lot of triple antibiotic paste. It looks very good in theory, but according to
cumbersome job. It is a cumbersome job.
Yeah, it's very cumbersome. And according to me, in private practice, I think nothing works better than calcium hydroxide with a silicon-based, vehicle oil.
Yeah, you cannot. I would like to add a point. You cannot prepare this triple antibiotic paste and store it in a.
You cannot.
You have to make it fresh. That's where you get the results. So it is a little bit cumbersome procedure. If you have time, you can make it freshly prepared. If you have a busy practitioner, I use calcium hydroxide most commonly as an intracanal medicament. That works good for me.
And coming to Dr. Parag, your other questions, current file systems and their indications, advantages, disadvantages, they were all covered in the initial part of the lecture. You can watch
Alright, sir. I couldn't. Okay, sir. Okay, so I couldn't join early.
Yeah. We'll be sending the recorded lecture link to all the attendees. Okay, so you can re-watch the lecture, especially the initial part, which has all the answers to your questions.
I wanted to know one thing. Can I?
Yes.
Yeah, please.
Yes.
So can you identify the lateral canals with an IOPA film?
Not always. See, if the lateral canal is greater than 0.5 microns or millimeters, I would say maybe, or maybe in the CBCT, but not always. It's very difficult to identify lateral canals.
Sometimes when there's a lesion developing on the lateral surface of the root, there are chances that there is a lateral canal causing that kind of a lesion. Sometimes this is because then you end up placing the medicament, and
that is a clue that there could be a lateral canal.
Could be a lateral canal.
Identifying them is difficult on a radiograph. As I said, radiograph is a 2D image of a 3D object. Probably, maybe I've seen some lateral canals in CBCT, but that is also not sure shot. It only gets, if you clean them well and if they get filled up. Sometimes, to my surprise, I have come to know this later after I have obturated the canals. It surprises me. Endodontic is a surprising field.
Okay. Next, I think we have covered almost everything. Sealpex sealer from Kerr, is it good? What is your opinion about the material?
Sir, if you ask from an endodontist point of view, I don't like Sealerpex for the reason, as I mentioned, it does not fulfill the ideal requirements of a sealer because it is very much resorbable. It has an excellent flow.
It is not insoluble. Yeah, it resorbs very fast.
I have my cases, sir, where I filled it with the canal and I got a good 3-dimensional fill. And the next week or 10 days, 15 days down the line, the sealer is missing from the lateral canal. It has an excellent radiopacity, excellent flow, but it is not dimensionally stable. Because here the people don't keep a follow-up. When they keep a follow-up, they'll get to know.
Okay. How to manage hot tooth?
See, hot tooth is a condition where the pulp is hyperemic, right? So the first step in managing a hot tooth is profound anesthesia. Your anesthetic technique should be proper and correct. Sometimes you have to give more loading dose than is required.
And an intraligamentary injection works miracles in such cases. Even a block may not work, but an intraligamentary always works.
Yes.
Always works.
Yes. And prefer using Articaine in hot tooth. That helps better.
And sometimes pre-op analgesics given to the patient, that also help.
Yes.
If you, yeah, but it's difficult to say because when you're starting out, this is a hot tooth. But and reassurance, yes, reassuring the patient that an intrapulpal injection will work. Just reaching that area of pulp is important. You reassure the patient, go slow by slow, step by step, reach that pulp orifice, and then give an intrapulpal. Again, works wonders.
That works wonders. She's absolutely right. Next question: best way to obturate tooth with wide apex? MTA, biodentine. I showed you cases. That's the best thing right now available on the market. So I would undoubtedly go opt for MTA. MTA or biodentine, both.
Which apex locator is the best, sir? So somebody's asking that.
Yeah. But already answered.
Already JM Morita.
Yeah.
JM
Morita, he already said in detail. MTA putty used as a filling material instead of gutta pacha.
MTA putty used as a filling material instead of gutta pacha. The drawback with putty MTA is it is very sticky, right? So when you tend to obturate putty MTA in the canal, it sticks to your plugger. So when you lift your plugger, it tends to get lifted up. You cannot compact it as densely the way you compact the powder and liquid. So putty MTA is good for sealing perforations, but when it comes to packing in the canal, it is little messy. You can use it, but it is little.
There's a lot of residue in the lateral. I mean the canal per se. Yes.
Yeah, it flows from the canal and comes up above. So compaction with putty MTA is little tricky, and it is very sticky and it is messy.
Okay. Can you talk about phantom pain after RCT?
Phantom pain after RCT, so far I've not come across this much, but yes, the post-op pain, what we have managed mostly, they are managed by analgesics and anti-inflammatories. But his question is not specific. Is it like how to manage this pain or what causes this pain?
Okay. How to clear pulp chamber from excess resin sealer from proper resin bonding of post-obturation material?
Okay, now there are good degreasing agents available in the market. One is from Septodon called hydrosol. One of you can it's nothing but a isopropyl alcohol, but in its pure form. You can also use 70% isopropyl alcohol to clean the chamber, right? Or you can use any acidic content such as citric acid, malic acid. Leave it for a minute and then you wipe it off. You remove it with a cotton plug. That will clean the canal. That will enhance your bonding. And after that, there are some conditioners also available which enhances containing polyacrylic acid, which enhances the bonding to the dentin.
Removes the smear layer also.
No, actually the question was attributed to after we obturate all the sealer which sticks to the walls, how to clean them, which affects the bonding. Anything else? Any other questions?
Which material is best for obturating primary tooth?
Primary tooth.
Calcium hydroxide, according to me.
Calcium hydroxide. That is the best, I think.
Should be resorbable, most important.
Yeah, because roots are going to resorb, so you cannot put a permanent filling material in there. Roots are going to resolve. You cannot put a permanent link. Calcium hydroxide, along with one of my pedodontists had mixed zinc oxide powder with calcium hydroxide and placed it. But I think calcium hydroxide with iodoform is the best.
Oh, no antibiotics, even if there is a periapical pathology. I'm a strict, I'm completely against antibiotics unless there's any systemic condition involved.
Yeah. If patient is having swelling or if there is an abscess draining from the canal, only then I prescribe antibiotics. 99% of the endodontic cases can be treated with anti-inflammatories, analgesics.
Antibiotics in endodontics are only given to avoid super infections or secondary infections. They do not, the minimum inhibitory concentration is never attained in the periapical region. So it's not going to help you in solving. You will have to locally go and debride it through a root canal. Antibiotics is only for to avoid super infection in
Yeah, so
endodontics.
the more antibiotics you give, the more resistance the patient develops. Endodontics is a mixed kind of infection. So it's not a specific, species-specific antibiotic. So there are so many, there's spores, there are bacteria, there are viruses in the endodontic infection. So what all, you're not going to give antifungal, antimicrobial, so many antibiotics. So antibiotics has minimal role in endodontics unless and until there's abscess, frank abscess, or there's a swelling.
Okay, last two questions.
Yes,
Any
sir.
recommendation for downpack and backfill?
You mentioned it.
I mentioned
All done, no?
yes, ENQ
Yeah.
plus.
Yeah, okay. So primary teeth obturation is done. Without sealers, without sealer setting, can we do core? Will it affect bonding?
Sealers, the main use of the sealer is to fill the spaces which are not filled by a gutta percha, right? See, the gutta percha is a thicker material. When you soften the gutta percha, it might adapt to the canals, but it will not flow in the lateral canals. The sealers will flow in the lateral canals. So the role of sealer is to fill those tiny, intricate spaces where your gutta percha is not able to flow. But core, giving a core is definitely. You have to have a good coronal seal.
Does periapical radiolucency
Disappear.
disappear with time after a successful root canal treatment?
It should. Ideally, it has
Yes,
to.
definitely. Why not?
Yeah.
I have hundreds of cases where I have, you need a follow-up. In India, the patients don't follow because it depends on the size of the periapical radiolucency. Sometimes it may vary from 6 months to up to 4 years. If it's a periapical cystic lesion or granuloma, takes time. So you need to have a follow-up.
Okay,
Can we
coming to the
use
last
Metapix for obturation in primary teeth?
Yes.
Doc,
Sorry?
I personally use Metapix Plus in all my primary teeth.
Sorry, what was the question? Can we use?
Can we use Metapix for
obturation
obturation
primary
in primary teeth?
Primary teeth, you can use Metapix.
I use Metapix Plus. It has amazing flow and
Yes.
it's very good. I vouch for that material.
See, for me, the disinfection is more important than what you put in. So Metaplex Plus and Metapex and Metapex Plus. I've used both. For me, both have. Yeah, she's right. It has a good flow, and it does not cause any post-op pain.
It doesn't cause much pain.
Yeah.
In fact,
in my practice, I see very less pedo patients. Maybe one or two cases a year. 90% of my practice is limited to retreatments. So I see a lot of retreatment cases.
so then you must be using calcium hydroxide even more, sir.
Using water-based calcium hydroxide in
Not oil-based.
because
Any particular reason for that, sir?
because oil-based calcium hydroxide is very it is very difficult to remove from the canal. It is very sticky, and it takes time to resolve. Secondly, if some amount of oil-based calcium hydroxide is left in the canal and you obturate the canal over a period of time, that will get resolved or dissolved. So leaving behind tiny spaces, right? and then we do not realize what went wrong where. So primary reason is it is very difficult to remove these metapex or oil-based calcium hydroxide from the canal. It hampers the adaptability of the seal of the. It also interferes in sealing between the sealer and the wall. If you are using a resin sealer, so there is some kind of bonding between the canal wall and the resin sealer. Secondly, if you are using bioceramic sealer, definitely it is going to leave behind some spaces when this metapex resorbs. So we do not know tiny spaces which will be recolonized by the bacteria soon and fails the weakening. So I do not want, I want a clean shaped canal. I want only my sealer and gutta percha in the canal, nothing else.
Great. So that brings us to the end of today's session. Amazing lecture and detailed answers in question and answer session by both the speaker as well as guest moderator. I thank both of you for taking your time and with all dedication, with great patience, answering each and every question. And I'm sure the audience had great time and received a lot of benefit from this session. And soon we'll be sending out a simple 5-point summary of today's lecture, and also we'll be sending out the link, the YouTube link to the recorded. So wait for our message. All the registered delegates will get this message on your WhatsApp. And once again, I thank today's guest speaker, Dr. Harsh Amlani, and today's guest moderator, Dr. Urshita Jikar Wadia, both from Vadodara. And that brings us to the end of today's session. Soon we'll be announcing the 4th episode of 4th season of ICPA clinical series. Each episode, one clinical challenge. Thank you and good night.
Thank you everyone for being a wonderful audience. Thank you once again. Thank you, sir. Thank you, sir.